I have no conflict of interest to disclose. زي ما انتم عارفين, pain and agitation or distress are very common in the critically ill patients in the ICU, بالذات المرضى اللي بيكونوا على الميكانيكال ventilation, المرضى اللي بيكونوا intubated. عشان هيك analgesia and sedation are commonly used and needed in the ICU. في عوامل كثير في مرضى الاي سي يو في الكريتيكال ill patients that can lead into pain, agitation, distress and delirium. يعني for example things that can cause pain في الاي سي يو, tubes سواء endotracheal tube, chest tubes, procedures, lines, even immobility and routine patient care like turning can cause pain. Also for agitation, many factors can cause agitation and distress. The physical restraints, لما يكون مريض unable to communicate, ventilator dysynchrony, anxiety, even dyspnea, shortness of breath, thirst, and hunger. So many factors that can lead into pain and agitation in the patient in the ICU. That's why we really need to use analgesia and sedation in the ICU. الجزء الأول راح أحكي عن البين, analgesia and analgesia in the ICU. والجزء الثاني راح يكون عن الsedation. هلا incidence of pain in the ICU is high زي ما حكينا. So ICU patients routinely experience pain. 50 to 80% of ICU patients actually report pain. زي ما حكينا, routine patient care, immobility, trauma, surgery, lines and tubes, they all can cause pain. كمان procedures that are done in the ICU can cause pain. Self-reporting of pain is the gold standard. يعني أحسن إشي لما المريض is able to tell you that he's in pain. بس المشكلة إنه كثير من مرضى ال ICU they cannot tell you. They are either on the vent, they are sedated, they are altered. But as a gold standard, self-reporting is the best. In these patients who can report it, 0 to السكيل اللي بنعرف اللي هو pain scale 0 to 10 is valid and feasible. هلا المرضى اللي they cannot report their pain, we have to rely on other things. في عندنا pain scales راح نحكي عنهم. These are very beneficial. There are clues from the patient that can indicate that he or she are having pain. Facial grimacing, combativeness, diaphoresis, hyperventilation, tachycardia. These can indicate that the patient is having significant pain. بس راح نحكي كمان عن ال scales that we can use as tools to measure pain. In patients in the ICU, we should assess and address pain initially. Should be a priority. We should assess the pain regardless of their ability to communicate. يعني سواء بيقدروا يحكوا إنه they are in pain or not. It should be a routine thing to assess for pain. And when we say analgesia sedation, that means to use analgesia first before sedation to reach the sedative goal. يعني you should not use sedation in a patient who is already having pain. عالج البين في الأول, الألم, then you can go into sedation. In general, IV opioids are the first line choice for non-neuropathic pain in the ICU. Doesn't matter. All IV opioids can be equally effective إذا عملنا titration. Second choice, we have some second line to use for pain, not as effective, but still can be used, like acetaminophen or paracetamol. Neuropathic pain medications like gabapentin. Sometimes low-dose ketamine. It's really rare to be used. There are some other non-medicinal adjunct pain measures that can be used, like pre-procedural cold therapy and even massage or music. لما نحكي pre-procedural cold therapy, احنا بنجيب ice packs بنحطهم على procedure site for like 10 minutes before we do the procedure. This has shown to decrease the pain and to cause some analgesia. زي ما حكينا, you should start with pain assessment first, whether self-reporting or based on the scales, and if pain is present, treat it with analgesia. That should be the first thing to do. After that, you decide if you need sedation and then decide which sedation you will choose. بعض المرضى, they might be good just with analgesia. Not every patient in the ICU needs sedation. They might do okay just with analgesia. Not everyone, of course, but some patients. So start with pain assessment and management initially. One of the best guidelines for using analgesia and anesthesia and sedation in the ICU is the guidelines from the Society of Critical Care Medicine. Last guidelines came out in 2018. But they recommend that pain should be routinely monitored in all ICU patients and should be treated before sedative agent is considered. زي ما حكينا. Usually this is done by the ICU nursing. They should assess the pain for every patient at least a couple of times every shift. في عندنا tools or skills that we can use for patients who cannot report pain. The most important ones are behavioral pain scale and critical care pain observation tool. راح نحكي عنهم كمان شوي, وراح نحكي عن الكومبوننتس تاعتهم. Vital signs should not be used alone. ما تعتمد على vital signs by itself to assess pain. يعني ممكن تعطيك a clue, بس يعني should not just rely on vital signs and not to assess pain. زي ما حكينا, ال IV opioids are drug of choice for analgesia in the ICU. They also recommend to use preemptive analgesia prior to procedures. يعني before you do a procedure, قبل ما تحط chest tube, قبل ما تعمل line or do other procedure, you should consider giving the patient analgesia before that. Patients who have neuropathic pain, patients with neuropathy, you can use neuropathic pain medications زي gabapentin, carbamazepine, along with opioids. البين assessment في الاي سي يو زي ما حكينا, السيلف reporting is gold standard, بس not always possible. لما يكون مريض sedated على الفنتليتر, او لما يكون مريض عنده altered mental status, he cannot report the pain. هنا بيجي دور using the scales and the scores, and these have shown to improve pain management, decrease mechanical ventilation time, and decrease the length of stay in the ICU. لما نستخدم هاي البروتوكول او هاي السكيلز in a protocol, outcome is great. I mean, many studies have shown positive outcome, decreased pain score, improved pain scores, استخدام اقل للsedatives, استخدام اقل للopioids, less side effects from opioids, decreased length of stay in the ICU, and decreased mechanical ventilation time. Also decreased mortality. هذا هو ال behavioral pain scale. It's one of the commonly used. بيعتمد على 3 components: facial expressions, upper limb, and compliance with the ventilator. يعني when your patient is having grimacing, retracting the upper extremities, and fighting the ventilator, that's an indication of significant pain. هلا كل component the score is from 1 to 4, and the total range, the total score range is from 3, which is no pain, to 12, which is the maximum pain. The other scale it's called critical care pain observation tool. Kind of similar components. The scoring is kind of different. The scoring is from 0 to 8, with 8 being maximum pain. بس بيعتمد تقريبا على نفس الكومبوننتس: facial expression, body movements, muscle tension, compliance with the ventilator. وإذا المريض not on the vent, بيعتمد على vocalization. يعني somebody who's crying or moaning, that's an indicator that the patient is in pain. الانالجيزكس for pain and sedation زي ما حكينا you might consider using just analgesic to it might be enough for some patients actually without using sedation. The most commonly used اللي راح نحكي عنهم هم morphine, fentanyl and hydromorphone. ما في comparative trials to compare them. All of them are effective when titrated. Some of them are more potent than the others, but if you titrate it, eventually they will reach the same point of pain control. None of them is ideal. The ideal analgesic will have rapid onset, ease of titration, lack of accumulation, low side effect profile, and cost effective. Unfortunately, none of them has all these criteria together. None of them is ideal. Each one has pros and cons. لما نحكي عن المورفين, everyone يعني we are very familiar with the morphine. Peak onset is within 20 minutes. Duration of effect is 2 to 6 hours. Everyone's familiar with it. Disadvantages انه it can accumulate in renal failure لانه it has an active metabolite. And also it can cause hypotension in some patients due to histamine release. Usually it's more given as intermittent dosing, 1 to 4 milligrams q 1 to 4 hours. IV infusion can be used, but it's not really common. يعني أنا بذكر آخر مرة استخدمنا المورفين drip in the ICU كانت few years ago لما كان في shortage of fentanyl. So it's more used as intermittent IV push. على الجانب الآخر, fentanyl is the opposite. It's much more used as continuous IV drips in the ICU. Fentanyl, immediate onset of action, peak within 5 to 10 minutes, but the duration is short, 30 to 60 minutes. The advantages, it's rapid onset, ما في active metabolites, and it can be used even if the patient is allergic to morphine. The disadvantages in short duration of action. And if you're going to give pushes, you'll give it maybe every 1 hour because it doesn't last long. And disadvantages also, it can accumulate and have an extended half-life if you use it as a drip for a long time. Hydromorphone or diluted, it's the most potent. The peak onset is 5 to 15 minutes. Duration of effect is 3 to 4 hours. Unlike morphine, it does not cause hypotension in general and has no active metabolites. Physicians are less familiar with the hydromorphone than morphine and fentanyl, but this is improving. Everyone is getting more comfortable with the hydromorphone now. Again, it's more used as intermittent IV rather than IV infusion, and it's usually in lower doses because it's very potent. And if we are going to compare the potency, 1.5 milligram of hydromorphone is equivalent to 10 milligrams of morphine and 200 micrograms of fentanyl. The common adverse effects for opioids in general include respiratory depression, hemodynamic instability and hypotension, more with morphine, CNS depression, and gastric retention and ileus. Many patients who are getting high doses of opioids, they develop also constipation, and they will need prophylactic laxatives. في specific side effects for different opioids. يعني the most important ones to remember, neurotoxicity for miperdine or Demerol, which is not commonly used in the ICU because of this. Fentanyl can cause rigidity, or there's a syndrome called rigid chest wall syndrome, not commonly seen, but this is unique to fentanyl. Remifentanil can cause hyperalgesia, which means when you stop it, the patients become much more sensitive to pain. Remifentanil is not much used anyway. الجزء الثاني from the talk, agitation and sedation. راح نحكي عن السيداتيفز. زي ما حكينا في بداية التوك many factors في ال ICU can lead into agitation. Hypoxia, hypotension, injuries, delirium, pain, infection, or even the medications اللي احنا بنعطيها او اللي ما بنعطيها it can cause agitation. فلما نحكي عن الميديكيشنز في ادويه او drugs if we stop it the patients become agitated like benzodiazepines, alcohol, nicotine, even beta blockers and clonidine. If you stop it abruptly والمريض كان متعود عليها it can they can get agitated. على الجهه المقابله في ادويه احنا بنعطيها للمرضى وكان cause agitation. Steroids, which is very common to be given, benzodiazepines, anticholinergics, او اذا المريض كان جاي داخل على المستشفى و he's using some drugs like amphetamine or cocaine. These can cause a lot of agitation. هلا the goal of sedation in the ICU to have a balanced light sedation. يعني ما بدنا يكون under sedation ما بدنا يكون over sedation لانه في مشاكل associated with both. هلا في under sedation المريض might self extubate, might cause injury to himself وكمان will be fighting the ventilator. So we do not want the patients to be under sedated. على الجهه المقابله over sedation it will increase the length of stay لانه المريض ما راح يصحى. If you are giving mega doses of sedation it will take him a longer time or take her a longer time to wake up. It will increase the length of mechanical ventilation. It can cause anxiety and depression, and it can lead into more complications like ventilator-associated pneumonia. نرجع لل guidelines or recommendations from Society of Critical Care Medicine for sedation. They recommend maintaining a light level of sedation because this is associated with improved outcome. يعني النتائج مع light sedation much better than heavy sedation. هلا في مرضى راح نحكي عنهم هذول exception راح يحتاجوا deep sedation بس for the in general for the ICU we try light sedation. Propofol and dexmedetomidine are preferred over benzodiazepines in mechanically ventilated patients. So benzodiazepines should not be your first choice. كمان في exceptions راح نحكي عنهم بس your first choice should be propofol and dexmedetomidine which is Precedex. Of course after you have already addressed and treated pain. So sedation medications should be titrated to maintain a light rather than deep level of sedation unless clinically contraindicated. يعني إذا كان المريض عنده increased intracranial pressure, إذا كان المريض paralyzed, إذا المريض كان عنده status epilepticus, you might need deep sedation. But in general we prefer light sedation. برضه في عنا scores or scales that we use for agitation راح نحكي عنهم. Most commonly used and validated RAS, which is Richmond Agitation Sedation Scale, and Sedation Agitation Scale, SES, which is less used. هذول اللي بنستخدمهم routinely في ال ICU. For some patients as certain circumstances بنستخدم other monitoring tools مثل ال BIS monitor. That's mainly for patients who are paralyzed. ومرات ممكن نستخدم ال EEG for patients who have non-convulsive seizures just to monitor for any active seizures. They also recommend either daily interruption of sedation or a light target of sedation. So for most patients, we should try to stop the sedation and interrupt the sedation once a day, just to make sure that we are not over sedating them.
Dr. Shadi, 5 more minutes.
Okay. Richmond Agitation Sedation Scale is most commonly used. It's from -5, which is unarousable, up to +4, which is combative. في العادة احنا بنستخدم for most of the patients 0 to 2. So لما احط انا الاوردر for the nurse titrate the sedation for RAS scale of 0 to -2. For some patients زي ما حكينا ممكن نحتاج deep sedation، بس بالتاكيد ما بدك يكون السكور في البلس سايد يعني +1 or +4. Sedation agitation scale kind of similar, but it starts from 1 to 7, and for this you will target a score of 3 to 4. When choosing a sedative, you have to consider many factors. في البداية, if there are ongoing pain, if there's a pain, you should start with analgesic. Substance abuse might increase the tolerance, so patients might need higher doses or multiple sedatives. Seizures, for patients with seizures, you might use propofol or benzodiazepines because they have anti-seizure activity. Anticipated time on mechanical ventilation. إذا بتتوقع إنه المريض راح يكون على mechanical ventilation for a short time, maybe a couple of days, better to start with the propofol because it's faster to stop and it's أفضل في المرضى لما يكون short term mechanical ventilation. Home medication use, hemodynamics. لأنه some of these sedatives they can cause bradycardia and hypotension, so you have to consider these. يعني إذا المريض bradycardic, we should not really use propofol or Presidex لأنه both of these can cause bradycardia. Propofol can cause hypotension. كمان you should look at the renal function and hepatic function. You should try to avoid benzodiazepines and impaired renal function, and maybe avoid propofol with impaired hepatic function. The most commonly used زي ما حكينا propofol, dexmedetomidine, which is Presidex, and the least favorite is benzodiazepines. نحكي عنهم بسرعة. Propofol is a GABA agonist and NMDA antagonist. Rapid onset, short duration, dose usually 5 to 85 microgram per kilogram per minute. The maximum is 85 microgram per kilogram per minute. Metabolized in the liver, so if there is a liver failure, it can accumulate, and it comes in a lipid formulation, so it can give some calories actually. And the nutritionist or they deduct this from the tube feeding. بيعطوا لسه tube feeding. Advantages: it's good to use in patients requiring frequent neurologic assessment. يعني you can stop it and the patient wakes up easy, بيصحى بسرعة for neurologic assessment. كمان it's good to use in patients thought to require short intubation time, and it can be titrated rapidly within 5 to 10 minutes. You can change the dose. Disadvantages: it can cause hemodynamic instability زي ما حكينا, hypotension, bradycardia, and it has more adverse effects in long-term sedation. Complications: respiratory depression. So propofol should not be used in any patient who is not intubated. زي ما حكينا, it can cause hypotension and bradycardia. It can cause hypertriglyceridemia. عشان هيك احنا لازم before we start propofol, we should get a baseline triglyceride level and then check the triglycerides every 3 days or at least once a week. And sometimes it can cause acute pancreatitis. There is a syndrome called propofol-related infusion syndrome. It's rare and not commonly seen, but it's fatal. More seen in children actually. It can cause bradycardia, arrhythmias, fatty infiltration of the liver, severe metabolic acidosis, rhabdomyolysis, and renal failure. But again, this is rare. Dexmedetomidine or Presidex, selective alpha 2 receptor agonists. Onset of sedation within 15 minutes and peak is 1 hour. Good thing about it that it's you can use it even if there is renal failure. Advantages: هو بيعطي conscious sedation. يعني
Dr. Shadi, 1 more minute.
Okay, I still have a few more slides. Can I get a few more minutes? Do you have time?
على طول دكتور شادي. 3 more minutes.
Okay. So المريض لما يكون على Presidex ممكن يكون calm and relaxed, but at the same time صاحي يعني doesn't have to be completely sedated. You can use it even after extubation. Disadvantages: It can cause bradycardia in some patients. It has a mild analgesic effect, but it's not enough by itself for analgesia, and it can be costly. هو أغلى من ال other sedatives. Benzodiazepines, you are all familiar with it. It's the least favorite, but still sometimes used. Midazolam, which is Versed, lorazepam, which is Ativan, and these can be used in drips or pushes. Diazepam, which is Ativan, it's usually pushes. It's not commonly used صراحة في ال ICU. Midazolam has a shorter half-life than lorazepam. Lorazepam is one of the possible side effects is metabolic acidosis and renal failure with prolonged use. It's very rare to see lorazepam drips currently in the ICU. You might see pushes, but it's very rare to see the drips. The guidelines from Associated Critical Care Medicine, daily interruption of sedation should be routinely used, and light level of sedation زي ما حكينا should be routinely used. Daily interruption of sedation results in shorter duration of mechanical ventilation. ممكن يقصر فترة mechanical ventilation by 2 days, وبالتالي shorter ICU stay and fewer tests for active mental status. Spontaneous awakening trial is another term for interruption of sedation. يعني before you interrupt the sedation, you have to make sure إنه المريض ما عنده seizures, ما عنده alcohol withdrawal, not agitated and not paralyzed, and normal intracranial pressure. إذا عندك أي واحدة من هذول, you should not try to wake up the patient. هلا في عنا special circumstances. في الalcohol withdrawal, benzodiazepines are the drug of choice. Status epilepticus, benzodiazepines and propofol are frequently used. Increased intracranial pressure, you need deep sedation. You might use more than one sedative, propofol, fentanyl, and midazolam. You just need to keep them in deep sedation, -4. Also, for therapeutic hypothermia patient, they need continuous infusion of sedation. And patients with neuromuscular blockage, also they need to be deeply sedated. زي ما حكينا, daily interruption of sedation with spontaneous breathing trial, less mechanical ventilation days, shorter ICU stay, and daily interruption of sedation with early physical therapy results in better return into independent function, with less delirium and less ventilator days. Recommendations or summary: use analgesia first approach for sedation is recommended. Light level of sedation is recommended rather than heavy sedation, unless there is a contraindication. And daily sedation interruption should be carried out in order to assure sedation is minimized when possible. شكرا جميعا. بتمنى أكون قدمت شيء مفيد لكم. شكرا لحضوركم.
شكرا جزيلا دكتور شادي، محاضرة قيمة، موضوع كثير مهم. الله يعطيك العافية. أنا عملت ميني سيرفي في الشات عن شو السيديشن الموجود في الأردن. الأجوبة كانت بروبوفول استخدموه كثير، ريميفنتانيل، فentanyl, morphine. I don't know if they were talking about sedation or analgesia in ICU. They said only few hospitals in Jordan have Precedex. Dr. Shad, a few questions.
Yes.
Should you start bowel regimen to prevent constipation with every patient you put on opioids for sedation?
Ideally, if they are on continuous drips, you should use some laxatives. This can be adjusted, of course, during the course of the stay.
دكتور شادي، سؤال ثاني. إذا عندك مريض normal blood pressure, would you prefer which sedation? We're gonna give brief and clear. A lot of people will be managing ICU patients with it. If I am your president and you want to tell me I'm going to sedate this patient, which one would be your first choice?
For patients with?
For patients on mechanical ventilation, he has normal blood pressure, he doesn't have specific contraindication.
Most commonly, it's propofol. This is usually first choice for most patients.
And would you recommend?
As long as the pain is addressed.
Would you recommend keeping continuous Versed infusion as a last resort?
Yes, and you can even consider giving intermittent doses of midazolam. Doesn't even have to be continuous infusion, but for some patients it's needed. It should not be your first choice though.
شكرا جزيلا دكتور شادي، الله يعطيك العافيه. شكرا